Our speaker is Dr. Bernard Natukunda, who is a Hematology and Transfusion Medicine faculty of medicine at Mbarara University of Science and Technology. He will be speaking on pre-transfusion testing and alloimmunization.
My topic is on pre-transfusion testing and alloimmunization, moving from the blood center, the labs, towards the hospital, to the blood bank. Basically, to show you that when there is improved pre-transfusion testing, the occurrence of post-transfusion alloimmunization and its consequences will be prevented. So what is pre-transfusion testing? This refers to all the serologic tests, the immunohematological tests, plus the clinical and history checks that are involved in determining compatibility between a potential recipient, a patient to be transfused, and the blood donor. And these are largely done in hospital, in a hospital transfusion laboratory, so that there is no wastage, there is no transfusion reaction because of the incompatibility. And its purpose is to select for each recipient the components, the blood components that will be biologically compatible after a transfusion has occurred. It's very important that there is compatibility. Otherwise, we shall go back to what used to happen in the history of transfusion medicine, when they didn't know about blood groups or blood group antigens that are on these components, that are on these cells. Red cells have antigens, platelets have antigens, and the white cells have antigens. So when there is incompatibility, there's going to be a reaction when you are antigen negative, when you are the patient, and you get a wastage. What about alloimmunization? Alloimmunization refers to the formation of antibodies or alloantibodies against blood group antigens. Usually there is a genetic difference between a blood donor and the recipient, and that leads to post-transfusion alloimmunization, or a difference between the mother and the fetus, which occurs in pregnancy because of the paternal antigens that are carried by the fetus, and there is maternal alloimmunization. What are the consequences of alloimmunization? Alloimmunization can be due to red cell antigens, but can also be due to platelet antigens or HLA antigens. In that case, you talk of platelet alloimmunization, and then there is destruction of the platelets that have been transfused, or HLA. That's why the previous speaker, Grace, was talking of record reduction. When there is record depletion, HLA antigens are going to be reduced, and we don't see the consequences of HLA alloimmunization. Now, for red cell alloimmunization, the consequences include hemolytic disease of the fetus and newborn, and also acute and delayed hemolytic transfusion reactions. And these can come with serious morbidity and mortality when the incompatibility is major at the ABO level. The figure here shows us the clinical importance of antibodies to blood group antigens. There are so many blood group antigens, not just ABO, which is usually taught and referred to, and RH. These are 30 blood group systems. It's got from Professor Devon Steele's article in Blood in 2009. But currently, there are 33. We have had Forsman, JR, and LAN added to these. Now, when you look at these, the ones in red, those blood groups in red, they have antigens that often stimulate formation of alloimmunization, formation of alloantibodies. Groups like ABO, MNS, RH, KL, Duffy, Kid, Diego, Dombro, Colton, HXK, and globoside. Very, very important. The ones which are occasional are shown in yellow, systems like P1, PK, Lutheran, Cartwright, Indian, RAF, and JMH with II. The ones in green rarely cause immunization. Lewis, XG, Sienna, LW, Rogers, Garbage, Chroma, Ops. OK, and G, RH, AG. RH used to be in the system, of course. The ones which are newly discovered also have little significance. But at least we should be aware that when we match for ABO, we still have all those that are in red waiting to cause a problem to our patient. Alloimmunization in sickle cell disease patients. Sickle cell disease patients are known in the transfusion literature that they form antibodies. They have a high risk of antibody formation because they are usually transfused. They are multiply transfused. But also because the literature used to come from the Western world, from Europe and USA, where blood donors are Caucasians and sickle cell patients are black like us. So they have seen, they have reported 18 to 76% of patients forming antibodies in the Western world. Whereas other multiple transfusion patients were at the rate of 5 to 20% antibody formation. The most common blood groups involved are the RH, which used to be called rhesus, KIR, KID, Duffy-Lewis, and MNS systems. And the consequences of those who get alloimmunized, that once the patient comes with the antibodies, it is very difficult to get compatible blood because it's going to be cross-matching compatible. That leads to delays in transfusing the patient who is usually very sick and in need of urgent transfusion. And once you transfuse, they're going to get transfusion reactions, both acute but commonly delayed. They are going to have HDFN, or hemolytic disease of fetus and newborn. Autoimmune events may occur. They get autoimmunization in addition to alloimmunization. And once they have antibodies, then the situation is worse to get the blood. Also, unfortunately, they get the hyperhemolysis syndrome. And this is a destruction of the transfused cells. Even the parent cells, the red cells of the patient get destroyed. The hemoglobin after transfusion becomes less than the one before transfusion. And transfusion can even be fatal in the hyperhemolysis syndrome. I think it's due to a bystander mechanism. What about alloimmunization in Africa? There isn't much that has been said about alloimmunization in Africa, but we have 4 countries that have done research: Mali, Malawi, DRC, and Uganda. And the data shows that up to 10% of the patients have clinically significant antibodies because of the transfusions, 1 to 10%. And the common specificities include big C, D, and big E, which are from the RH system, and big S from the MNS system. Worth noting is that antibodies to big K of the K system were rare compared to big S. And also worth noting that we did not see differences between sickle cell disease patients and other polytransfused patients. All of us, whether sicklers or not, had the same rate of antibody formation because, of course, donors and patients are homogeneous. We have the same genetic makeup, unlike in the Western world where sicklers are black. What about the situation in Uganda? Alloimmunization in Uganda was studied at 2 referral hospitals, Mulago National Referral Hospital and Mbarara Regional Referral Hospital. At Mulago, we looked at post-transfusion alloimmunization, and 642 patients were studied, 2/3 of them being sicklers, and 1/3 being the other frequently transfused patients. At Mulago Hospital, we studied maternal alloimmunization, and 2001 pregnant women were studied for the evidence of forming antibodies against their pregnancies or against previous transfusions. And once you have those antibodies, and you're in antenatal, and you're pregnant, the chance that the antibodies cross the placenta and cause damage to the fetus are very high. Results were that 6.1% of all transfused patients, whether sicklers, whether OMT, had antibodies circulating in their plasma. These are dangerous antibodies that are IgG, that of IgG isotype. And 6% of the D-negative pregnant women had antibodies also in their plasma. These were anti-D antibodies. These have been published in Transfusion, in Fox, and in Transfusion Medicine. How is alloimmunization prevented? because it is very, very important to stop this complication, which has serious consequences in our patients. The prevention for antiplatelet and anti-HLA alloimmunization is different. We now discuss the prevention for anti-red blood cell alloimmunization. The practice in the Western world is to get a patient, and these are sickle cell disease patients, and do extended phenotyping. ABO, instead of stopping at D, they also do full RH and care, pre-transfusion, before immunization. And after that, do CEK, antigen big C, antigen big E, and big K matching, so as to prevent alloimmunization. But some patients need genotypic matching because they have variant antigens. When you test D positive, for example, by serology, that's not the end of the story, because at your genetic level, you may actually be having a variant. And when you do PCR, you may find that patient is actually antigen negative or is having a D variant, which is maybe a partial or weak D, and which could cause immunization, or which could immunize, or which could cause immunization. So they go further and use DNA techniques for typing these patients and donors, so as to prevent any possibility of further immunization. You first immunize to show that we have a variant. And once we go to our patients who are antigen positive, don't expect to form antibodies, but some will form antibodies. So in that case, we do their molecular immunohematology, we do their DNA and see the genetic basis of that anomaly. What's the way forward for sub-Saharan Africa? We need to improve our practice, our clinical translation practice, our laboratory practice. And in that way, we advocate for a policy of a standard pre-transfusion testing in sub-Saharan Africa. And that can be something which is not very complicated, just introducing screening, just introducing the use of Combs test, the use of the indirect antiglobulin test. We do two things, and that's how we are taught, especially in Uganda, group and cross-match, which is we miss out the second step of group, screen, and cross-match. So we should group, screen for antibodies, and cross-match for patients who are likely to get exposed to blood cell antigens or are likely to get transfused many times. These include sickle cell disease patients and other multiple transfusion patients. Now, when we screen and we find that there are some who are immunized, we could think of a limited phenotype matching. Instead of extended phenotype matching, we think of a limited phenotype matching for these antigens, the cache antigens, big C, big E, big S, as opposed to the shake one, which is big C, big E, big K in the Western world, so that those who have shown immunization don't get additional immunization, and that, of course, depends on resources. The cheaper one is the group screen cross-match to prevent trouble. Once trouble has come, do phenotype matching, which is CES. What's the situation in Uganda? Pre-transfusion testing in Uganda. You know, colleagues, transfusion medicine is all about, according to the World Health Organization, is that part of the healthcare system that deals with the appropriate provision, appropriate supply, and use, and utilization, both supply and use of human blood resources. In Uganda, a lot, as you've heard, has happened on the supply side, but not on the utilization side. What we are doing in the hospital is not standard. We need to standardize it. The UPDS does everything 100%, brings blood to hospital. But our practice is limited to ABOD typing and room temperature cross-matches in saline, and of course on a tire. This has problems because we do not screen for these immune antibodies and we don't do complete cross-matches. We do not detect clinically significant antibodies. The antibodies are IgG and they are reactive at 37. Our practice detects IgM antibodies at room temperature on a tire. We don't do the IgG, These ones which are immune. These ones of IgM are natural occurring. Everyone has them. If you are group B, then you have anti-what? You have anti-A. You are group A, you have anti-what? Anti-B. Because of exposure to the environment and diet during childhood, all of us have the natural occurring antibodies. But once we've been pregnant, once we've had blood transfusions, then we have the clinical sequence antibodies which we don't look for. And that puts our patients who have those antibodies and pregnant women at risk of what? Of the transfusion reactions and hematologic disease of the fetus and newborn. So policy makers, leaders, doctors, practitioners who are here, why don't we improve our practice and save our patients? Healthcare is improving, but our practice remains like that of 1940, when they had not discovered Combs reagent, had discovered the Combs test, they had discovered RH system. Pre-transfusion testing has a few requirements. You need to positively identify your patients and their blood sample, review the records, test donor blood, do ABOD grouping, detect antibodies, select appropriate components, test using cross-match, and do proper labeling. It's a must. And we have an important operational document known as the blood request form. This must be standardized across the country. It must be well filled by us doctors and the blood who take, and you need unique identification number, patient's full name at a minimum, or their ID card, or their license number, and all that. Additional information like age, sex, diagnosis, important, transfusion, pregnancy history, and if the patient has special needs, it's not common here, irradiated components or CMV negative components, but the lab should reject your requisition if you don't have all the information, and if the information is not accurate, and if it is illegible. There are some specimen requirements pre-transfusion because the testing is only as good as the sample that is submitted. So we need to train our staff how to correct the sample and label the sample. To avoid wrong blood in the tube, because you may go this way with a labeled tube, correct blood, mix it up, make sure the identifications are there, and the time and your identification with the phlebotomist. The sample should be into stoppered tubes. And if you cannot positively identify the patient, do not draw the sample. First, make sure the patient is identified. And label it at the bedside. If you take off samples and you go to your area to sit and label, that is wrong blood in tube already. And the samples should not be kept for long. If the patient has a history of pregnancy or transfusion in the last 3 months, make sure after 3 days you draw fresh samples. And if there is no, you want to investigate transfusion reactions, make sure you don't throw away the donor segment and the recipient sample. Keep it in the fridge for a week, for 7 days after transfusion. Because the patient is going to react, and you are not going to investigate because the patient has already got the transfusion. The reaction could be a delayed one after a week or even 2 weeks. Records, this is a challenge because we usually ask patients a history of surgery, a history of transfusion. There is no record. The lab should keep a history, a serological history of the patient so that we compare the current results and the previous results. If the patient has a discrepancy, make sure the discrepancy is resolved. And if there is no history, it's good to get a second sample and you compare as a quality control check whether the results match. And of course, an important history is that of clinically significant red cell antibodies in the patient because they are very dangerous. You give blood, they have put all the money in correction, you transfuse it, it is destroyed. The patient suffers morbidity, but also the government suffers the cost of that blood unit that is wasted. Instead of investigating the cause of the reaction, you add more blood, also wasted. The blood stock is wasted and is finished when we could easily prevent this by screening and screening. The pre-transfusion testing is the shared responsibility. We have actions of the blood supplier, which some people call the blood center, and actions of the transfusion service, which some people call the blood bank, which is in hospital. Blood center will do the ABOD of the donor, screen the donor, because the donor who has antibodies will also pass them to the patient passively, and when the patient is antigen positive, there is also a reaction. They do titer testing, of course, HIV, syphilis, hepatitis B, C. They label and distribute. Perfect. In the hospital, in the blood bank, you need to investigate the ABOD of the patient without necessarily doing weekly, screen the patient, do their previous record check, set components, do a cross-match, which we shall say whether full or abbreviated, and label. Then at the bedside, ensure the patient is the right one. And do proper labeling. Then when you are issuing, ensure the right blood goes to the right patient. How do we test for ABOD? We should test in two ways. We should do the forward test and the reverse test. And in most places in this country, we only do the forward test by testing a known red cells from the donor of the patient with reagent anti-A and reagent anti-B. And then also test for blood group D using direct agglutination forward test. As a quality control check, you should also use unknown serum from the patient or the donor with reagent A1 cells and B cells. And once they don't match, you don't issue the blood before resolving the discrepancy. Of course, in an emergency, you give O negative red cells and AB plasma. Antibody detection tests. These antibodies are the ones called immune antibodies or unexpected antibodies, which are not anti-A and anti-B, or anti-A, B. When it is clinically significant, it's the one that checks at 37 and has history of causing transfusion reaction, hemolytic disease of fetus and newborn, and unacceptable survival of the transfused red cells. Detection of red cell antibodies is enhanced by use of the comb's serum or antihuman globulin reagent or comb's reagent. This figure shows antigen-antibody reactions. An optimum reaction takes place in the middle, in the zone of equivalence. You don't need too much antibody, otherwise you get a Poisson phenomenon. You don't too much antigen, you get antigen excess. So you need a serum to cell ratio that is optimal in the middle. You need a right temperature, 37, right incubation time in the incubator. You need a right pH, that the reaction takes place at neutral pH at 7. Also need the concentration of the suspending medium. Is it normal saline? Is it least? Is it enhanced? So all that has to be taken into consideration. Now we have our important test. Very, very simple test, but somehow which we don't routinely use. The Combs test, which is now known as the antiglobulin test. Two types, direct test, the DAT, and the indirect test. In the direct antiglobulin test, you're looking for antibodies that have, you're looking for antibodies that have already coated red cells in vivo. Agglutination sensitization has occurred in vivo. So you take off blood and directly add Combs reagent. Directly add antihuman globulin reagent. And there is direct agglutination, meaning that this patient has what? Antibodies at the IgG and are coating red cells. But they're not agglutinating because of the nature of the IgG antibody. If it was IgM, you would get initial reaction, what you get on a tile when you are cross-matching. But in this case, you don't get it because of the nature of IgG, because of the zeta potential. So you have to add an anti-IgG, an antibody against IgG, to bridge the gap, and you get a reaction. But in vivo, of course, it would cause morbidity. The indirect test is different because the antibodies here are circulating in plasma. So you have to, first of all, incubate the red cells, which are usually cells from the donor or cells which are reagent cells in your screening test. Incubate them, they coat. After coating, after incubation time, you add your Combs reagent, and agglutination takes place, meaning that the original plasma had antibodies circulating. The same thing which occurs when someone has been transfused. So to prove that, you do that test. Or in a mother who has had alloimmunization, antibodies in her serum are circulating, and the risk of hematological disease of fetus and newborn is high. Still more on screening and identification. That test is done using what's known as a 3-cell panel, antibody screening. These 3 cells are from group O donors. They have most of the antigens of interest. D, big C, big E, little c, little e, M, big S, little s, big K, little k, Daffy A, Daffy B, J, kid A, kid B, and P1, Lewis A, Lewis B. Now those ones are on this cell in the 3-cell panel. Once you put the patient's plasma or your plasma of interest or serum, there's going to be a reaction. And you can use the gel test, which you see there, those cards. The first card, I don't know how to use this. The first one here is positive. This one is weakly positive, and that one is negative. That's the gel card. And once it is positive, then you go ahead to identify the type of antibody. Otherwise, you want to give antigen-negative blood. So you use an 11-cell panel here, and you test the plasma. And those reactions undergo an incubation in a special incubator, which is not shown, and you centrifuge them using a special centrifuge. Once, of course, we could use our own centrifuges using the tube test. This is known as the gel test. So it comes in an antigram. Then you record the positive results there, and you compare them with how the individual antigens react. And that is shown there. Under the indirect antiglobulin test, or under the indirect Coombs test, the results are there. First cell is negative, so whichever is negative becomes a candidate. Second cell is positive, whichever is positive becomes a candidate. Third is positive. So the 3 here are all positive. So this antigen, which is cont'd B, is not a candidate. Here in Duffy A, the first is positive, first is negative, second is positive, third is positive. It becomes a candidate. You proceed and finish the whole panel, including an auto control. If the auto is positive, you are in trouble. You are into autoimmune hemolysis, autoimmune hemolytic anemia. But if it is negative, luckily, then the antibody is external. It is a narrow antibody. And in that case, you can see it corresponds to anti-big S. That's how they identify antibodies. Then you test for the blood donor, where they are antigen S what, antigen big S what, negative, and you give the blood to avoid the reaction. There is what's known as a type and screen. This protocol is also common in the Western world, and it is emerged as a safe alternative to a full cross-match. They don't cross-match. You know, they also have what's known as a computer cross-match. But after doing a type and screen, that detects up to 99% of all unexpected antibodies in a patient, and unless the cross-matches are not done. You know, when you say group and cross-match 4 units, Dr. Kaja is booking for blood. Instead of saying group and screen, then when the patient needs blood, when the patient is Dr. Mujenyi's obstetric or preoperative, they are going to be screen negative, and when the cross-match is not done, when they need blood, it is immediately cross-matched. Immediate spin cross-match is done. Within 5-10 minutes, you get your blood in the theater. When the screen is positive, you get antigen-negative donors, and you are ready. That's type and screen. There are questions, especially in Uganda, in sub-Saharan Africa, about the cost of the technology. So we did the cost analysis and cost-effectiveness analysis to see whether it can convince policymakers, Ministry of Health, to improve hospital transfusion practice. What did we do? We evaluated cost-effectiveness using the healthcare provider's perspective, where we had 2 scenarios, a limited testing scenario and a universal testing scenario. In a limited testing scenario, we said, can we introduce this in referral hospitals, Marago and all the other, I think 14 or 15 referral hospitals, or can we do it in all hospitals in the country? And we compared tube testing and gel testing to do antibody screening or cross-matches only. Because when you cross-match, when you do a full cross-match, it is also going to look for antibodies. So when you do antibody screening, it costs you $8.7 for a tube test and $20 for a gel test. When you do a cross-match only, $0.35 for a tube test and $0.85 for a gel test. When you do full cross-match, you can still pick out the antibodies, which you pick out in the screen. And this cost does not mean the cost of a test. It is a healthcare provider's perspective. We consider cost of equipment, of hospitals, of staff, everything. You have to account for the cost. The cost of a test, of course, will be very, very little compared to this. And the conclusion was that introduction of red cell antibody screening as part of pre-transfusion immunohematology testing in Uganda was cost-effective, and we really pray that it can be introduced. Details are in our paper of last year. What about the time? Some people may say, what about turnaround time? It takes you 5 minutes to get uncross-matched blood, but it also has a 5% risk of acute hemolysis and cross-matched, group O or anything that you order. When you do ABOD typing only, it takes you 15 minutes for your blood to be ready from the lab, but also has an equivalent rate of 5% risk of acute hemolysis. Now, when you screen, type and screen, it takes you 45 minutes. The risk goes to 1 in 1,000. When you type and screen and add a computer cross-match, it takes you 1 hour, but risk is also 1 in 1,000. When you screen and do our serological cross-match, the time is about 2 hours to be ready, but the risk goes to 0.1%, less than 0.1%. So in conclusion, it's that overall, about 5% of the patients will have an antibody anyway. The risk of an acute hemotransfusion reaction will be diminished only when our antibody screening is performed. The key word, just one word, screen, screen, and screen, so that you don't get transfusion reactions. And finally, what about the future? The future of pre-transfusion testing in sub-Saharan Africa, we need to improve and change our strategy. We need to do full testing, introduce it for people who are chronically transfused, or who are repeatedly transfused, polytransfusion patients like sickle cell disease, cancer, and the other patients who commonly receive blood. We need 3 steps, not 2. 1, do the ABD grouping, donors and patients. 2, screen for immune red cell antibodies in patients. And 3, do a room temperature saline cross-match that we do if the screen is negative. If it is positive, identify the antibody and give antigen-negative blood. Now, for the other patients, the rest of us who may need a transfusion for the first time, let's use a complete cross-match, not an abbreviated one at room temperature, but one that is an antiglobulin enhanced cross-match at 37 degrees centigrade using comb's serum or using comb's reagent is what we recommend. Thank you very much, ladies and gentlemen. Best wishes.